Good afternoon, ladies and gentlemen, and welcome to the Surgeon 2021, Port Harcourt 2021. Welcome to this very important event organized by Mega Life Sciences to talk about overview of viral hepatitis as part of the activities of Surgeon 2021 and as part of their corporate responsibility to disseminate information on hepatitis on this very important day. We all know that today is the 28th of July, which is celebrated every year as the World Hepatitis Day. And this year's theme was aptly crafted as Hepatitis Can't Wait, or Hep Can't Wait. That means that whoever is out there that is at risk of getting hepatitis cannot afford to wait to get screened and know his status, and also cannot afford to get diagnosed late. Therefore, we should promote awareness. You can see across the globe, it doesn't have racial discrimination, doesn't have age discrimination, doesn't have gender discrimination, nor does it stop across boundaries of geographical regions. All people across the world cannot afford to wait anymore, and that's the theme for 2021. I'm going to go through this outline of introduction. We look at the liver in health and disease. We look at definitions of viral hepatitis. We look at clinical outcome and complications of viral hepatitis. How do we evaluate patients with viral hepatitis? Treatment, prevention, and challenges, and some take-home messages. But I'll be focusing mainly on the two dreaded viruses of chronic sequelae, B and C. So as a way of introduction, the liver, as we know, is the largest intra-abdominal organ with several functions running up to more than 500 different functions, basically summarized into metabolic, synthetic, detoxifying, and elimination, and also some immunological function and storage function, particularly storage of essential iron, vitamins, chemicals, and albumin. Now, that function can only be maintained by a healthy liver. When the liver is diseased, those functions are lost, and you can imagine losing more than 500 functions of the most largest organ, internal organ of the human body, leading to cirrhosis and even, unfortunately, in some cases, to liver cancer. So we all want to see the difference of a healthy liver in the top left and all the other ones depicting cirrhosis and cancer nodules in the down to bottom images. So what is the global burden of this viral hepatitis? Globally, it is estimated that up to about 325 million people, some up to 400 million people live with chronic hepatitis B and C. And as at the last count in 2017, about 257 million, with 68% in Africa and Western Pacific, carry hepatitis B on a chronic basis, while 71 million people across the globe in all regions of the world are infected with hepatitis C. Now, this is a huge burden, and there's rising death rates from liver cancer and liver cirrhosis from these two important viruses. There has been global increasing burden of mortality from these viruses, as seen in the orange line that is continuously increasing steadily. But even diseases like HIV, hepatitis, and tuberculosis and malaria are on tuberculosis, malaria, HIV are on the downwards trend, but hepatitis continue to rise in terms of mortality. Unfortunately, as huge burden as this disease is, or these diseases are, only about 5% or less of people living with chronic viral hepatitis are aware of their status. And we will come to see later why the WHO and the World Health Assembly is promoting a 2030 target, which will come in the later part of this presentation. Excuse me. So what is viral hepatitis? The term hepatitis refers to any inflammatory process of the liver causes necroinflammation, basically defined in terms of temporal, not in terms of severity of sickness. As many people confuse chronicity with severity in the non-medical circles. When we say acute hepatitis, it just means that hepatitis have lasted less than 6 months in that individual, while chronic have lasted more than 6 months. Doesn't necessarily mean that it's more severe. And there could be an acute injury on top of a chronic event, which is acute on chronic hepatitis. Now, looking at this viral hepatitis, what are the causes? What are those viruses that causes hepatitis? Generally, classified into hepatotropic viruses, which have affinity for the liver, and these are the ones that are alphabetically named as A, B, C, D, E, with the B, C, and D in some instances having chronic sequelae. While a huge host of other viruses can cause hepatitis, not as hepatotropic viruses, but as part of systemic viremia. And this includes Epstein-Barr virus, cytomegalovirus, adenoherpes, Coxsackie, yellow fever. But our focus here is on those hepatotropic viruses, as I mentioned earlier. Now, what is the clinical cause of viral hepatitis when you develop it? It all depends on the immunity of the individual, and largely that also dependent on the age of acquisition. If you acquire your infection in the early childhood or in the neonatal period or in infancy, the chances of chronicity goes as high as 90%. While in adult, because of matured immune response, only about 5% that progress to chronicity. But acute hepatitis can lead to complete recovery, or unfortunately, some 1% of them can develop fulminant hepatitis without background liver disease and may die or recover. About and also majority of early acquisition of hepatitis B go to chronicity with some chronic sequelae of cirrhosis and even liver cancer and some extra hepatic manifestation. As I said earlier, the outcome depends on the host immunity, which solely depend on the age at acquisition. You can see in this slide, if you look at hepatitis B, if you get the infection during infancy and early childhood, 90% will go to chronicity because you don't have good immune response. Older children, about 20%, and adults, as I said, about 5%. On the contrary, the less immunogenic or the less virulent hepatitis C virus, which can go silently in the acute stage, up to more than 80% of them will progress to chronicity. Now, how do one know that he has viral hepatitis? It's very important for the public to know that a lot of these people are asymptomatic, and over a long period, some have described as being a silent killer. In other words, you may carry the virus without, if there's no significant damage to your liver, the virus is there in the system. By the time you develop symptoms, that's symptoms of decompensation. So that's why you can't afford to wait to get screened so that you know when the disease has not yet damaged your liver significantly. Non-specific symptoms sometimes requires highest index of suspicion, particularly in acute diseases that are not decompensated. So you can move from there to chronic cirrhosis and liver cancer. They're on different causes. And unfortunately, if that is not detected and treated early, the liver will get damaged, and it's typical of the cirrhosis level that can get decompensated with jaundice, with varices, vomiting of blood, and all complications of chronic sequelae of chronic liver disease. Now, cirrhosis is the one that typifies the chronic liver disease, but also chronic hepatitis and some progressive cancer. These are all together forms chronic liver disease, but cirrhosis is the one that typifies when we see someone with ascites, jaundice, edema, and all the stigmata. That's typical of cirrhosis. And that is that nodular image in brown there, and you can see the cancer nodule, that if the patient is not picked early and acquired and get liver transplantation. So many other complications can follow when you decompensate: ascites, infection of the acidic fluid of spontaneous bacterial peritonitis, GIT bleeding and bleeding viruses, liver failure, hepatic failure of renal failure of hepatic origin called hepatorenal syndrome, and cancer. There are a host of other complications of decompensated cirrhosis. And from historical perspective, we all know that in those days we used to hear about infectious and serum hepatitis, because referring to the orally transmitted A and E viruses, and the serum transmitted hepatitis B, C, and D. And also, before they were actually identified and subtyped, they were called non-A, non-B in those days. Therefore, looking at these hepatotropic viruses, you have hepatitis A, B, C, D, E. The A and E just have acute sequelae. It doesn't need chronicity, but the B and C, which are shown in red there, are the ones that we are going to dwell on. E has particularly severe disease and outcome in pregnant women. So we should know that, so that when you have a pregnant woman with hepatitis E, they run a more aggressive course and may lead to poor outcome if it is not properly handled. B, C, and D can cause both acute and chronic disease, but B more than C in our environment. Although there are pockets of C in Africa, particularly Egypt and Cameroon, of which Egypt has done a lot of work at the government level towards eradicating this virus. And therefore, it requires the presence of B for it to replicate and infect humans. When they can go in together as co-infection, or come after B have established itself in an individual as super infection. Either way, when D go on top of B, it leads to more aggressive disease and difficult to treat. Now, looking briefly about the hepatitis A virus, this is the most common virus worldwide. About 20 to 40% of clinically apparent hepatitis in the acute stage are accounted for by hepatitis A, mainly fecal-oral, and is seen in overcrowded population, poor sanitary condition, or poor facilities, or where you have natural disasters. Most people that are infected, particularly children, are anicteric with non-specific flu-like symptoms. Adults may, however, develop icterus after acute infection. It is important to know that about 15 to 20% of people that have hepatitis A can have what you call relapsing hepatitis, where you have biochemical and clinical disease that is lasting up to 3 to 6 months. And 5 to 10% may have cholestatic pattern, actually, persisting with pruritus and jaundice. So no carrier stage for this virus, as we said earlier, and there's preventable vaccine available, about 95% reduction in the US since the vaccine for hepatitis A started in 1995. Prevention of hepatitis A usually through personal and community hygiene, proper hand washing, cook food properly, clean water supply, and then vaccine 0.5 ml in adults and adolescents and children, or 1 ml in adults with a booster just 18 months later. This vaccine provides long-lasting protection of more than 10 years, and 1 dose before travel to endemic areas is sufficient to protect traveler from acquiring hepatitis A. Now, the close brother of this virus that is orally transmitted is hepatitis E virus. I've said the only thing is similar mode of transmission, similar outcome, except the fact that has poor outcome in pregnant women. And there is a vaccine for hepatitis E is licensed currently only in China, has not been popularized across the globe. And also the same mode of prevention. Now, looking at the chronic hepatitis of B, C, and D, starting with hepatitis B, we know that about 2 billion, about 1/3 of the whole population, have some form of evidence of previous or present infection with this virus, and about 240 million chronic carriers exist across the globe, with about 1 million deaths annually accounted for due to chronic sequelae of hepatitis B virus. It causes about 80% of all liver cancers in human beings, and it has been described as the second most important carcinogen after tobacco, classified as class 1 carcinogen by the WHO. It is 100 times more infectious than HIV and about 10 times more infectious than hepatitis C virus. Effective vaccine available, but no cure up till now, unlike hepatitis C, which we'll come to here later. We all know about the structure of the virus, and the transmission is mainly vertical or horizontal transmission or through unsafe practices of using sharps or sexual activity, particularly multiple sexual partners without protection, using unsafe tattoo techniques, sharing of personal hygiene items, and therefore can spread in household if they are not well educated. Healthcare workers that are not vaccinated are at risk, and we should know it's not spread through just casual contact, food, sharing utensils, as long as there's no cut and there's no blood mixing with the injury on the body of the contact. The virus is a very, very resilient virus, very tough virus that can survive extreme of temperatures and dry surfaces for days, and even extreme of frozen environment. So it's a very, very contagious virus. We've already talked about the outcome of this in children and adults, and progressing to cancer more in those that develop cirrhosis. But however, it's important to know that hepatitis B can develop cancer directly as being a reverse transcriptase virus. So you have de novo HCC without passing through cirrhosis. Unlike hepatitis C, that you must have cirrhosis before you develop cancer due to C. B can go in 2 ways, either as de novo from just hepatitis to cancer, or from cirrhosis developing to cancer. Now, one of the difficult things about hepatitis B, and the fact that we don't have cure up till today, is the fact that it's a DNA virus, and therefore it encodes itself and integrates itself into the human DNA in the form of this cyclically covalently closed circular DNA, which is difficult to eradicate, even with the interferons. Now, however, we should know that not everybody have hepatitis B develop chronicity or chronic inflammation or cirrhosis. There's what we call inactive carriers. In those days, we used to call it erroneously as healthy carriers, but it has been changed to inactive because not all that are healthy, that are inactive, are actually healthy. So for you to have a definitive diagnosis of inactive carrier of hepatitis B virus, the ALT must be persistently normal, and the DNA must be less than 2,000 international units per mil, done every 3 monthly for up to 12 months. That is the technical definition. How feasible is this in our environment in terms of cost, lack of insurance? It's a huge burden on the patient to be able to answer that. Now, how do you make diagnosis? It could be clinical, radiological, serological, biochemical, or histological and liver biopsy. But with the advent of non-invasive markers of fibrosis like transient elastography and using other markers like APRI score, FIB4, FIB5, and other markers, we cannot assess the degree of fibrosis or even cirrhosis in the liver using non-invasive markers, unlike biopsy that we used to do before. And these serological markers are hepatitis B surface antigen and surface antibody, and then E antigen and the corresponding E antibody. Now, surface antigen is about the early marker that comes secreted by the virus when somebody is infected. And it's the mark of infection. Less than 6 months is acute, more than 6 months is chronic. Now, if you recover from the virus, you become surface negative and surface antibody positive. Now, E antigen is a marker of replication, but we should know that E antigen is only secreted by the wild virus. If you have a precombed mutant, you lose your ability to produce E antigen while maintaining the ability to secrete the HBV DNA. Now, we should know also that hepatitis B core antigen is not seen in the serum of the patient, but seen in liver tissue at immunohistochemistry. And then the core antibody, either IgM or IgG, depicting acute and chronic disease respectively. Now, quality control and correct interpretation of these markers are challenging our environment, even among clinicians that are not gastroenterologists. Now, what are the factors that you must consider before you consider somebody for therapy? Viral DNA level, ALT level, E antigen status, extent of liver damage, whether it's cirrhosis or no cirrhosis, whether the cirrhosis is compensated or decompensated, and other comorbidities like co-infection with HIV, HDV, and HCV, and other diseases that can affect the liver. Now, this simple diagram is not as simple as it said, but if you look at this algorithm, what you need to decide to start somebody for treatment, you need the DNA and the ALT. If they are both elevated, that patient go for treatment. If they are both normal, doesn't require treatment. But if there's discordant, you may have to go for liver biopsy or non-invasive marker to see evidence of inflammation or fibrosis and evidence of virus before you start treatment. So what are the treatment endpoints? Even though the ultimate aim is to lose the surface antigen, it's not always achievable. So if you can get normalization of ALT biochemically, or you have improved liver histology, or undetectable DNA, those are, or for those that are E antigen positive, if you achieve seroconversion from E positive to E negative antigen and E positive antibody, those are endpoints depending on whether you are E antigen disease or E antigen negative disease. And we know about the 4 phases of hepatitis that we used to call immune tolerant, immune reactive, inactive, and reactivation in those days, which has been changed now to E antigen positive infection and hepatitis respectively, and E antigen negative infection and hepatitis respectively for E antigen negative disease. And it's the hepatitis arm of these subclasses that require treatment in most cases. And we know that drugs that are approved for the treatment of hepatitis B, interferon, they call it the pegylated interferon, and the oral nukes, particularly lamivudine is no more promoted because of the resistant and that they develop in a significant number even after 1 year of therapy. But in Tecova, tenofovir, either tenofovir fumarate or tenofovir alafenamide, which is an improved version with renal friendly properties, are the ones that are approved for treatment. Now, sometimes you have to treat this patient for life, particularly the E antigen negative disease. And you should know that it's not a curable disease, but controllable disease with medication. How do we prevent hepatitis B? Health education, immunization. Taiwan and US have set example in terms of showing the efficacy of hepatitis B vaccine, which you require only 3 doses. And the bad dose is very important in every newborn. And then people that are at risk should also be vaccinated, and we ensure that our blood products and organs are safe for transfusion and transplantation, as the case may be. As we said earlier, D can coexist only with B, either as co-infection or super-infection. in about 5% of those HPV carriers, and that you diagnose it using IgM anti-D, or you do IgG anti-D in those that have resolved infection. Vaccination against hepatitis B will prevent this disease, and treatment is with interferon. Now, interferon is what you require to treat hepatitis D. And vaccination, the major drawback with vaccination in our environment is that you must make sure that that immune response is adequate to protect the patient or the individual that has been vaccinated. Ideally, one should check his surface antibody after the vaccination, and you need about 10 million units per mil to protect you for about 10 years or even stay for life. If it's less than 10 million units, you may require a boost and immunoglobulin to the baby. Now, hepatitis C. Now, this about 23 to 30% are symptomatic during acute infection only. Majority of them go silently. And chronic infection is as high as 80%, as I said earlier. And in the US, it has the highest genotype of genotype 1, about 60 to 70%. We have a 6 genotype described based on the differences in the nucleotides, about 1 to 6 genotype, about more than 70 subtypes. Genotype 1 and 4 are difficult to treat. These genotypes are based on the difference in the sequencing of the genome. If it's more than 30%, you have a different genotype. About 15% will give you subtypes, and we have more than 70 subtypes. The distribution across the globe, USA have more of genotype 1, also Nigeria and some part of Europe, 2 and 3 predominant in Europe, genotype 4 in Egypt and Middle East and Central Africa. South Africa have predominant genotype 5, along with Spain, France, Belgium, and other parts of Europe. Genotype 6 in Southeast Asia. Now, the global burden of hepatitis C is about 71 million people, as I said earlier, with Cameroon and Egypt have the hotspot in Africa. The burden in Nigeria, as of the 2014 national survey, prevalence of 2.1%. And mainly we have genotype 1 in this country, which is a difficult genotype. We've already talked about the outcome. Majority go to cirrhosis and require about long course of 20 to 30 years in some instances. There are factors that favor progression of hepatitis C: old age, male sex, HIV, and other sexually transmitted diseases, HBV co-infection, alcohol, iron overload, fatty liver, and use of hepatotoxic medication concurrently are all factors that favor progression. Now, in Nigeria, the algorithm, as we said, for hepatitis C, all you need to do is to do the antibody test first. That's step 1. If it is negative, of course, you don't need to go further. The other person doesn't need any further test. But if it's positive, it doesn't mean that you have current HCV infection. You need to confirm using the HCV RNA. If it's negative, also you stop there. If it is positive, you need to assess the stage of liver disease using preferably the non-invasive test of FIB4, APRI score, or transient elastography. And you need to know whether the patient is compensated or decompensated, because for decompensated disease, you cannot afford to give them interferon for those that are still using that in some regimen. And in Nigeria, the pan-genotypic DAS of sofosbuvir daglatasva or sofosbuvir valpartasva and some other combinations are what is recommended to start therapy on. They are all oral, they are pan-genotypic, and then you don't need to do end of treatment response. You just need to treat the patient for 12 weeks or shorter in some instances or longer if there's cirrhosis. And then after 12 weeks, you do SVR to see if there's sustained virological response. There are so many drugs of the DAS that has been discovered, but we all know that since 2003, 13 to 14, the first all-oral pan-genotypic drugs were discovered, and there are so many options with newer combinations emerging every day. So what are the goals of therapy for hepatitis C? You want to eradicate the virus as primary endpoint. If you can't achieve that, if you can get the secondary endpoint of preventing progression, cirrhosis, or cancer, or reduce the need for transplantation and enhance survival or quality of life, these are secondary endpoints. Now, the beauty of the DAS is the fact that they are very safe, they are very effective, more than 90% cure rate within 12 weeks of use, can be shorter in some instances or even longer if there is cirrhosis. They are all orally administered, so it's convenient for the patient. Compliance is very improved. They are expensive at this initial stage, but now a lot of support and a lot of generic ones are coming and they're getting cheaper. A lot of international and national partnerships are existing, with Egypt setting a good example for Africa. And I hope Nigeria should take a cue and take that as a challenge to eradicate hepatitis C in Nigeria. Now, there are a lot of problems across the globe about people going for studies or employment, sports, where some people are inappropriately discriminated because of just surface antigen status for hepatitis B. Now, this needs to be taken up at the policy level and also legislators, so that those that have active disease are the ones that need to be excluded. But those who have inactive disease that doesn't have anything, doesn't have to stop you from going to study abroad. I've got a lot of cases from Malaysia. People stop from going for PhD and masters because of inactive hepatitis B surface antigen status. Now, what is the role of liver transplantation? It's perhaps the definitive treatment for end-stage liver disease. It cures the diseases, particularly in cases like alpha-1 antitrypsin deficiency. But however, diseases like hepatitis B and C may recur in the graft liver, and therefore that need to be taken care of and be able to monitor the fact that when there is a reinfection in the treated area, so they don't lose the graft. Donor problem is a challenge in liver because we all have spare kidney with us, because God is wonderful. They created us with 2 kidneys so that we can give one to our relatives or loved ones. But we have only 1 liver. So initially there were problems with donors because you need to get cadaveric donor, but now we have living-related live partial liver donation from the right lobe, and even split liver for children exist. And therefore, liver transplantation is the ultimate for those that qualify, but you need to pick the patient early, and that using criteria of the MELD score or the UNOS to be able to prioritize the distance. Now, in response to the growing threat of this virus, the World Health Assembly endorsed the global health sector strategy for elimination of viral hepatitis by 2030. And the vision of this particular strategy is the fact that they want to have a world where viral hepatitis transmission is stopped and everyone have access to safe, effective treatment and care. And the goal is to eliminate viral hepatitis as a major public health threat by 2030. This is very important, and we need to do that as part of the in line with the SDG 3, target 3.3. And there are so many this is that you need to do to achieve that. Now, this 5-point elimination targets by the 3-dose infant vaccine currently is around 90 to go even above that or maintain 90% by 2030. The HBV PMTCT now currently around 50 to raise it to about 90% have access to that, and birth dose in less than 12 hours or 24 hours as the case may be. Also blood safety and injection safety 100%, harm reduction, and also HBV and HCV testing and treatment accessible to about 80% for treatment and 9% for diagnosis. Those are the WHO 2030 target. And I think Nigeria is doing a lot of work toward that already through the Hepatitis National Working Group to achieve these targets. How feasible are these? I think SOGIN, policymakers, civil society organizations, NGOs, and the federal government as drivers of policy should support this to be able to, so that Nigeria is not left behind in this 20 target of WHO to eradicate hepatitis B and C. Now, what is the take-home message? Viral hepatitis is a common problem worldwide. There are many misconceptions with regard to this virus, and awareness like this World Hepatitis Day should be used as an opportunity to clear this misconception, the myth. Viral hepatitis generates a lot of anxiety, especially with hepatitis B and C, and health education, vaccination, prompt diagnosis, and treatment and follow-up are key to controlling these viruses. Late presentation is a major challenge in our setting, as they come mostly when you can only offer palliative or supportive care. Not all those that have HBV require treatment. This must be emphasized to caregivers so that people that require treatment are carefully identified early, and the appropriate effective treatment are given and appropriately monitored so that the chronic sequelae are prevented. Now, while HCV is potentially curable using DAS for just 12 weeks therapy, HBV is not currently curable, but can be controlled effectively with medication. HBV vaccine is preventable. HBV is preventable using vaccine, but to date, there's no effective vaccine against hepatitis C, even though some are under development, but difficult because of the rapid mutation and the subspecies and quasi-species. USA and Taiwan, as I said earlier, are encouraging example to us in terms of hepatitis B vaccine. Over a decade, when they followed cohort, they achieved significant reduction in terms of infection, chronicity, and death from hepatitis B virus. And Egypt in Africa, which had prevalence of up to 15%, the highest in the world, the government took it upon itself to support hepatitis C eradication. And this program was even extended to Nigeria, about several tens of thousands of doses. And the access to which we have been challenging due to some bureaucratic, which should need to be overcome before we lose this opportunity. Other African countries have rightly benefited. And liver transplantation is better prevented than trying to get, because it's not within the reach of many of our patients. Currently, no center offer liver transplantation in Nigeria. And for you to go out, you need tens of millions with all the attendant problem of immunosuppression and its related problems later, because you need immunosuppression for life. Thank you very much. Thank you very much.